So acute kidney injury, we are going to talk about clinical manifestations, lab values, different causes, the phases of acute kidney injury. One thing that is nice is a lot of the diagnostics are going to be the same when we get to chronic kidney disease, end-stage renal disease, so we won't have to really go through those again because we're all talking about, the same assessment of the kidney. So acute kidney injury is sudden. Hopefully it's identified early and reversible. We're going to look at urine output, but also serum creatinine and our other diagnostic renal specific lab values. Chronic kidney disease, on the other hand, is gradual. Clients typically have no symptoms until it's quite advanced, and it's progressive and irreversible. So the whole goal with chronic kidney disease is to diagnose it early and slow the progression. So first we're going to go through acute kidney injury. So this slide is very helpful looking at the different causes of acute kidney injury. So I'm actually going to stay right on this slide and cover the next few slides right here talking about the causes of acute kidney injury. So pre-renal is anything to do with perfusion to the kidneys. Remember how we talked about that the kidneys are highly vascular, 20 to 25% of cardiac output, high blood flow per minute. If you have any reduction in perfusion, so if your client has an active bleed, let's say a bleeding ulcer, a GI bleed, or they have some sort of trauma where they have a significant blood loss, perhaps they're severely dehydrated, perhaps they have heart failure where they have decreased cardiac output. Anything that's going to affect blood flow to the kidneys is going to be a pre-renal cause. So that's important. Intrarenal cause of acute kidney injury is damage within the kidney to those renal tubules. So examples of intrarenal kidney injury would be acute tubular necrosis, where a client has damage to those basement membranes in the renal tubules. Perhaps a nephrotoxic medication, and I want you to think back to those nephrotoxic agents that we went through. So our aminoglycoside antibiotics, our high-dose NSAIDs, our ibuprofen, our gentamicin, vancomycin, our contrast dye, all of those things. Those would all be examples of intrarenal acute kidney injury. Postrenal would be involving the urinary system, so that's important. So involving the urinary system below the kidneys. So that would be the ureters, the bladder, the urethra. So if we had an obstructing stone in the ureter that was causing a backup of urine, that could be a post-renal cause. We just went through a male reproductive condition that could cause post-renal acute kidney injury. So what would that be? Absolutely, BPH, our enlarged prostate. With diabetes, we talked about a neurogenic bladder. That would be an example of a post-renal acute kidney injury where there's an issue with the urine outflow. The rifle classification classifies the degree of injury. So is the client just at risk? Do they have an actual injury? Has it progressed to failure, loss, or end-stage renal disease? The earlier that you can identify an acute kidney injury, the better the outcome. So there's 3 different phases of acute kidney injury. Not every client goes through every phase, so it depends on the cause of their injury and the individual patient. The oliguric phase is a 24-hour urine output less than 400 mLs per day. This usually occurs days after injury, and it can last up to 2 weeks. And as we go through the next few slides, I want you to think about how would your patient look in the oliguric phase. So I want you to already start thinking about that. So due to that decrease in urine output, clients are going to have clinical manifestations of fluid volume overload. So what would that look like? What would your patient look like? So they may have distended neck veins, abounding pulse, hypertension, edema, basilar crackles in their lungs, a weight gain. They're also acidotic. So kidneys play a major role in acid-base balance. So with the sudden loss of the kidney function, kidneys cannot excrete acid products. So you're going to see those rapid, deep respirations, the Kussmaul respirations. Your lab values, you're going to see evidence of acidosis. So the damaged tubules cannot conserve sodium, so we're looking at hyponatremia. There's also hyperkalemia. Remember, approximately 90% of potassium is excreted by the kidneys, and now there's been that sudden loss of kidney function. So we're dealing with a hyperkalemia, which we went through the symptoms of that and the function of potassium and the complications that the client would be at risk for. So go back and review hyperkalemia. There's also the buildup of waste products. So you're going to see increased BUN, serum creatinine levels. As those levels increase, you may see neurologic manifestations, fatigue, mental impairment. It could progress to seizures, coma. The next phase is the diuretic phase. The client starts putting out large amounts of urine. So they go from the oliguria to now urinating frequently, but very dilute urine. So clients may think that their kidneys have recovered because now they have to urinate all the time. The kidneys are on the road to recovery, but they're still damaged. They're still not concentrating the urine, and the client is really at risk for a lot of electrolyte imbalances and dehydration now. So large amounts of dilute urine, the client is at risk for hyponatremia, now hypokalemia, and dehydration. The last phase, the recovery phase, may take months to a year after this acute kidney injury to really return to normal. So the importance of follow-up. So every client that walks into a hospital is at some risk of acute kidney injury. You think about your surgical patient, your client having radiology procedures, your medical patient on a medical unit that has an infection and is on a nephrotoxic antibiotic. So there's a variety of different risk factors in acute care. So if your client does develop acute kidney injury, when you're doing your discharge teaching, the importance of follow-up, a nephrology follow-up, or primary care with really assessment of renal function is super important because it does take months to really fully recover. So for diagnostics, you're going to want to do that complete thorough history. Look at the serum creatinine. Also go back and see what is your patient's baseline serum creatinine. A lot of times you may not see an increase in the serum creatinine until 50% of kidney function is lost. A UA gives you very important information, so looking at specific gravity, sodium, kidney ultrasound, minimal side effects. There's no nephrotoxic agents that are used, and it still gives you good visualization of the kidney. So that's usually a first-line diagnostic test, a renal ultrasound. A renal scan really assesses blood flow to the kidney. So again, that could be a concern causing the acute kidney injury. Perhaps a CAT scan if you're questioning a mass. A renal biopsy to confirm intrarenal cause of acute kidney injury. So there's a variety of different diagnostics depending on your baseline, your history, and your assessment. So certain studies that use nephrotoxic agents would be contraindicated in a client that has acute kidney injury. So some examples might be an MRI or an MRA. So perhaps some of you have done a pre-screening questionnaire for an MRI with your client in clinical, and one of the first questions is, when's the last time you had your renal function, your BUN and serum creatinine checked? Because that's something that they're going to thoroughly assess before scheduling a procedure or a diagnostic test using the nephrotoxic dye. So the whole goal is to prevent acute kidney injury. If a client does develop acute kidney injury, identify it early and identify the cause, prevent any acute complications by managing those symptoms, and hopefully the client will have a full recovery. So the care of a client with acute kidney injury really depends on the phase of acute kidney injury. So the clinical manifestations. So if the client is in the diuretic phase, you may be forcing fluids, you may be administering IV fluids because they're dehydrating, they're losing large amounts of fluid. If they are in the oliguric phase and they're experiencing some acute fluid volume overload, they may require a loop diuretic or an osmotic diuretic. I&O is super important in your client with acute kidney injury. You're going to want to treat that hyperkalemia because it could result in a life-threatening cardiac dysrhythmia. So your client most likely would be on cardiac monitor. You would be doing an immediate dietary restriction. And then any one of these treatments would be appropriate for hyperkalemia depending on the level. It would not be your role as the RN to decide which treatment would be appropriate, but to understand the mechanism of action and how to safely administer and monitor your patient. So again, you do need to know these for the exam. So how would regular insulin and dextrose work to treat hyperkalemia? So remember, the regular IV push insulin is going to shift that potassium into the cell. You're going to be administering the 50% dextrose to prevent hypoglycemia. We talked about IV sodium bicarb and reversing that acidosis, and again shifting that potassium into the cell. The calcium gluconate, which is going to stabilize that myocardium and raise the threshold at which a dysrhythmia can occur. the oral preparations, or the sodium polystyrene sulfonate, which can also be administered as an enema to help exchange that potassium, that sodium for potassium in the GI tract, and cause the excretion of potassium-rich stool. We talked about specific nursing assessment that would be important to perform before administering this. And then the patiramir, which is a newer over the past couple years, which works in the same fashion. Those would not be for critical levels, because remember, they are going to take a little bit of time to have effect. So important to know those for the exam. So the term renal replacement therapy is referring to dialysis. So if a client is suffering life-threatening neurologic manifestations, a life-threatening hyperkalemia, metabolic acidosis, those would all be any sort of acute life-threatening complication would all be an indication for hemodialysis and acute kidney injury. So most common would be hemodialysis, where a client would have a temporary dialysis catheter placed and go for perhaps daily hemodialysis treatments based on their symptoms and their blood work. There's also continuous renal replacement therapy, which is very similar to dialysis, but it's a continuous 24-hour form of hemodialysis. It's very short-term, very expensive. It would be more common to have the intermittent hemodialysis. So nutrition is really important with all of our acute kidney injury, chronic kidney disease, end-stage renal disease. So that's something that you might want to make like a separate little study sheet just on nutrition, because it's all just a little bit different. So with acute kidney injury, clients need adequate caloric intake. It's primarily going to be from carbohydrates and fat. So they can actually have higher fat content. Just remember, acute kidney injury is a short-term, hopefully reversible condition. So you really, because you have that sudden loss of a kidney function, you really want to limit protein. Also limit sodium, because we're concerned about fluid retention. And patients may need very individualized, specific enteral nutrition even. So for your nursing assessment, definitely vital signs, I&O. You're really going to want to be looking at urine, overall general appearance, evidence of fluid volume overload. If they do have a dialysis access, you're going to really want to be assessing that, looking for any signs of infection. So assess your patient's mental status, their oral mucous membrane, their skin, their lung sounds, their heart rhythm. You're going to be looking at lab values, BUN, serum creatinine, GFR, potassium, sodium, those diagnostic test results. So I'm going to let you read through these nursing diagnoses and then maybe come up with a couple additional ones. So one that I can think of right now, risk for electrolyte imbalance. You could definitely look at nutrition, a teaching diagnosis. So overall, we want our patients to make a complete recovery, follow up, have normal electrolyte and fluid balance. So this is an important slide. I keep stressing the importance of health promotion and screening high-risk populations, because if we can prevent acute kidney injury, we can really prevent a lot of possible complications for our client. So you do want to monitor high-risk populations, our diabetics, our clients with hypertension, clients that are routinely taking nephrotoxic medications, or maybe they're hospitalized with a sepsis and they're on vancomycin. They really need very close renal function follow-up. You need to be assessing those levels of the antibiotic to make sure the dose is correct. Also, hypotension. I want to just talk about that for a minute. Anytime your patient is hypotensive, so systolic less than 90, that's going to impact perfusion to the kidneys. And if that's sustained, so a half a shift, a full shift, a couple shifts, just a client being hypotensive, they could develop acute kidney injury. So just making that quick phone call to the physician, informing the physician that your patient is 80/40 and you've rechecked it manually, they're asymptomatic, but maybe they just need a little bit of a fluid bolus to help prevent this acute kidney injury. That's important. Also, hypovolemia. You think about, again, clients with an active bleed, or a client having surgery and maybe having unexpected blood loss, or sustained hypotension. So any sort of post-op patient, any patient in critical care, basically any patient that walks through the door could be at risk for acute kidney injury. So you really want to be closely watching vital signs, volume status, blood work. I'm going to let you just read through the next 3 slides. So our older patients are at a higher risk for acute kidney injury. A lot of times they're on multiple different medications. They may have other comorbidities. So a dehydration can really put them right into an acute kidney injury, and they're at a higher risk for developing dehydration with diuretics, laxative use. They may need reduced doses of medications. So just lots of different things to think about with your older adult patient.